Hey everyone, my name is Sabrina and this is my innovation nursing project on reducing the impact of bias and stigma related to disability benefits in healthcare. The opinion that people who rely on welfare programs such as SSDI and Medicaid are lazy or undeserving of the support that they receive is an association that has been around since the New Deal and Great Depression and has continued until current day. You can see it in everyday conversations with coworkers and family members, and you can see it debated in political rallies and in internet articles. There are terms such as welfare queen or the undeserving poor that only serve to further this idea. That kind of widespread scorn is something that is really easy to internalize without realizing it, both as the person who needs to rely on those programs and as people interacting with it. The result of that is internal and external stigma. Internal stigma is a result of the toxic discourse in current society regarding people asking for and receiving help. People who receive disability benefits often think of themselves poorly, feeling guilty, shameful, embarrassed, or worthless for having to ask for that help. This is especially prevalent when they are learning about, applying for, and participating in these aid programs. 1 in 4 Americans who live below the poverty line and qualify for assistance, such as SSDI and Medicaid, do not receive any benefits. That is about 8 million Americans today who could be receiving help, better living conditions, and more affordable healthcare who don't because of the stigma. Manisha Gupta, a healthcare equity advocate who is also on Medicaid herself, said, "Being chronically ill already comes with an overwhelming set of challenges. When faced with a care system that burdens us with ignorance and sometimes blatant hostility, engaging with the institutions that might provide the tools we need is beyond tiresome. In fact, it's downright impossible." External stigma is the judgment and criticism that people receive from their surroundings, as well as the discrimination that they face and the misconceptions people have about just how much help SSD and Medicaid provide. Some people act as though people on SSDI and Medicaid are lucky, that they get a free pass to live through life without having to work, not understanding just how little income SSDI actually provides, as well as the roadblocks that being on Medicaid and Medicare create when seeking basic health care. Patients are often waitlisted for 4 months to 2 years before they are able to be placed on SSDI or accepted by Medicaid. In a 2021 survey, it was found that patients on Medicaid and Medicare were twice as likely to report unfair treatment from staff when compared to patients on private insurance. Specifically, they complained that staff and doctors shamed, ignored, and disrespected them due to their benefits and public insurance. This study also found that providers would change their clinical decisions based on insurance type and the assumed ability for the patient to pay for those services, as well as requiring an upfront payment, which was not required from those on private insurance. Medicaid and Medicare patients have a 1.6 times lower likelihood of successfully scheduling a primary care appointment, and a 3.3 times lower chance of getting a specialty appointment than those on a private insurance. This was found to be due to the lower payout from public insurance than private insurance, the administrative hassle associated with billing and getting prior authorization, and that patients on SSDI and Medicaid or Medicare are often more medically complex and therefore more costly for clinics to treat. This internal and external stigma results in people who qualify for welfare either not applying for it or not using it to the full extent possible. It also creates an environment where a patient is either unable to find doctors who will take them on as patients or who will treat them unfairly. This results in decreased health, quality of life, and personal independence for the disabled individual, as well as a decreased likelihood of those patients seeking out healthcare in the future. So, what can we do about it? Internalized bias is something that we all have. It's not something that improves without active effort on both our part as healthcare workers and on the part of the system. It starts with the environment that a clinic or hospital creates with their staff. Intentional hiring and screening questions, specifically looking for ableist beliefs or closed-minded people who would be more resistant to learning more about issues that they don't understand. We need to be hiring people who are empathetic, caring, and open to learning more. Staff training can help people identify bias that they are unaware of. This is already used in major hospital systems for discriminatory beliefs surrounding racial minorities and the LGBTQ. We can add to that by including disability and welfare-related questions. Some example questions would include, what assumptions do you have about people on SSDI? What kind of conversations have you had about disability benefits? What thoughts come to mind when someone mentions welfare programs? Once internalized stigma is identified and acknowledged, it can be improved on by education. For example, did you know that the average monthly income on SSDI in 2023 is $1,486? That is supposed to be able to cover rent, food, electricity, water, and transportation, as well as paying for their medical bills and medication. The average rent for a one-bedroom apartment in Everett, Washington right now is $1,600. Did you also know that you legally cannot receive help from family or friends without that monetary amount being removed from next month's payment? You can have monetary gifts totaling to $30 every 3 months, and any other unearned income has to be claimed. You are also only allowed $2,750 in countable resources, such as the money you have in your savings account. Do you think that people would criticize others so harshly for freeloading off government resources if they knew that that income doesn't even cover the average monthly rent? Because it doesn't sound very lucky to me. In addition to hiring more empathetic staff and providing training and education on stigma and bias, patient surveys can be utilized to assess for any discrimination impacting patient treatment and experience. There are existing surveys that often address things such as facility cleanliness, wait times, and if the patient would recommend the facility to a family member or friend. More specific questions can be included about any difficulty scheduling the appointment, the professionalism of the staff, and how they were treated during their appointment. These surveys would need to be encouraged by the staff so that they're not just buried in spam emails, but they could be used to reflect on staff behavior and if any policies could be added in by the clinics and hospitals to decrease discrepancies noted between patient treatment. This would help improve patient experience, which can decrease both internal and external stigma, as well as make sure that the patients feel safe enough to seek out healthcare. It also reduces the mental load on patients who are already dealing with chronic illness or disability and a lack of resource. On a larger scale, state legislation can help. A study found that states that have increased administrative hurdles associated with Medicare and Medicaid billing have significantly decreased Medicare and Medicaid patient acceptance when compared with privately insured patients, and that states with policies that reduce that administrative hassle have a comparatively higher patient acceptance rate. Insurance type and need for assistance should never be a barrier to receiving healthcare. We as individuals can write to our representatives about legislation, as well as voting for people who have healthcare improvements on their running platforms. Healthcare providers and staff need to have an increased understanding of the quality of life afforded to those on disability benefits, as well as to be held accountable for their biases. Training for staff and surveys for patients are just some of the first steps needed to improve care for this highly stigmatized population. Thank you for listening, and these are my reference pages.